As you can see, goal one, reduce and prevent substance misuse through education and community collective impact. And so that, of course, is the Prevention and Education Committee. And so what we are looking forward to doing in terms of objectives, reduce ED overdose visits by 10%, reduce the percentage of ED overdose visits among Black residents from 55 to 45%, reduce self-reported vape use by 5% of students surveyed in middle school. Now it's 16%, and high school 29%. And the data sources, of course, that we are using come from the Youth Risk Behavior Survey and also the NCDHHS Injury and Prevention Branch. Can you scroll? Thank you. Goal two, address substance misuse and harm reduction through intervention and treatment. The objectives increase the percentage of people with OUD who receive treatment from 0.4% to 0.5%. Obtain comprehensive data on patient retention rates from SUD treatment providers to establish a baseline retention rate. Enroll all eligible residents on Medicaid 100% and retain those who are currently enrolled. And the data sources you see there. And you can scroll up for goal three. Enhance continuum of care for individuals with substance use disorder. Conduct an assessment to determine why the Alcohol and Drug Use Treatment Center facility was not successful. Conduct an inventory of existing services, the possibility of enhancing those services and options to reduce use of emergency departments for detox. Explore existing continuum of care models in other counties, define best practices, and identify an ideal continuum of care from detox to inpatient and long-term treatment.
There's no data sources for this one because it's all about planning. So we have models to explore
Okay.
up here. So
Yeah. And so healing, well, you see what it says, but support stable housing for individuals with substance use disorder, complete a needs assessment, resource assessment focused on housing for individuals with SUD, reduce the total number of homeless individuals by 10%, reduce the number of Black or African American individuals who are homeless by 10%, reduce the total number of chronically homeless persons by 10%, open a day center for individuals who are homeless that includes connection to treatment for substance use disorder and harm reduction resources. Add a total of 20 additional beds in recovery housing facilities with no restrictions on MOUD. And you have some data sources there. And those are the new objectives that we have. One of the things that I do want to say about prevention and education is that vaping is not the only thing that will be addressed. Marijuana, anything else that shows up in terms of opioids and other things are still included, but they're not listed specifically there. So we're still working on those. Thank you, Lacey.
you're welcome. Now, I should have mentioned they're not exactly finalized. They're all final except for this goal number 4. We had too many to choose from, and I think Wendy wanted to maybe use this meeting to pick our final 3. Is that right? Oops, she's frozen.
Yeah, okay. You were frozen and now you're muted. Okay.
Can you hear me now?
Yes.
Okay. I might need to turn off my camera actually. If I'm going to turn my camera off. Okay. Yeah, I first just wanted to just get general feedback from hopefully everyone is feels good about what we've come up with. You know, we it was very hard to come up with things that were going to be measurable as well as can be implemented within 3 years. We're going to have a shorter, time span to revisit these goals. So I just first wanted to get any feedback and then move on to the last item, which we really need to get. We need to pick from those. So just want to open it up for any comments from everyone, and please introduce yourself too. And feel free to jump in. And I don't know, do you want to put it back up again, Lacey, so people could see?
Well,
Sure.
Helen has unmuted. So Helen, did you have something to say?
Durham County EMS managed the community paramedic program. No, my request was I need to see them again because
Sure thing.
Okay, so let's look back at goal 1. Any feedback on goal 1? Because this is the final review.
And this is over 3 years. So goals and objectives for 2028. Well, 3 years, yeah.
Okay, and so let's go on to goal 2. If you could scroll down to that, Lacey.
Are you seeing it? I just scrolled, but
You're good.
Yeah,
maybe it's slow.
you're
Okay.
good. That's great. Anyone have any feedback on this? Okay, and then we'll go down to 3. Okay, and then we'll go down to the last. Oh, somebody want to jump in? Go ahead.
I was, yeah, she scrolled down to what I was looking for, the models to explore. This is, I think a lot about what we're doing in EMS, community paramedics, with our MOUD program and trying to reach out in the community and be a viable option for people who are getting started with MOUD. But I see many times that a lot of work is very good work is being done. It doesn't seem to incorporate some of what we're trying to do. And I just want to make sure that we have a place in some of this. And that's what I was looking to see. So thank you.
Okay, well, that's a really good point, Helen.
Well, I think that would maybe under B would be when we're conducting an inventory of the services that already exist. We have some really good services, and where the holes are was the idea. I wasn't in this breakout group, but I think that's what they meant. I mean, one of the biggest holes we've been talking about is the detox center, residential detox center, which some of these models have. And we've invited a speaker today from Healing Transitions to talk about that, actually.
Okay, go.
Helen, does that seem okay to you, that second objective? Do you feel like that covers?
Yes.
Okay. Okay, great. So the last one, goal 4, around housing, obviously, 1, 2, 6 different objectives is too much. So we really wanted to get feedback. We want to just pick 3. And then there's the other option to combine B and C together. So we'd love to hear what if you have to pick 3, what do you think would be the most important objectives for us to focus on? Could you scroll down a little bit, Lacey, so that we can see all of F? Okay, great.
I scroll up or down? Wait.
It's good there. We can see F.
Okay.
Where did the numbers of total homeless individuals come from?
The point in
That's,
time count. Yeah, go ahead, Wendy.
yeah, I was going to say the pit count. So you're absolutely, yeah.
Because those numbers are
When
probably much higher.
Right. But that's the number that we were using. And if you want to use a different source of data, but I guess do you have a suggestion of another data point, Helen?
HMIS has a better number of unsheltered homeless than point in time count. Because as you know, point in time is just one night, right? Out of the entire year,
Mm-hmm.
and which makes it not completely representative of the number of people who are living homeless in our community. HMIS has a lot more information and is supplied by our coordinated entry system. So those numbers would be a little bit better. The NC Coalition in Homelessness is working. They're our lead agency for HMIS, and so they work with our lead agency for the HSAC and the continuum of care, as you know, to get these numbers. I just saw a presentation today that had a much higher possible homeless rate in Durham. So that's fine.
So, well, Helen, we can definitely change that to HMIS data. Could you get to Lacey that, we'll still use the 10%, but if you could get those, if we pick
Right.
pick these B, C, and D, to use that as our data point.
Yes, I'll get with Lacey to make
So
sure we have the best
who
information
does the pit
available.
count? Who's doing the pit count then? Wendy sent me a report on the pit count. That's where these numbers come from.
The pit count is managed by the lead agency, which until this year was the City of Durham Community Development Department. That department has now been merged with Community Safety, and Safety has now, as part of the HEART team, has a homeless how was it HOPE? They call it HOPE, and I'm still trying to remember what the HOPE stands for, but they are now the lead agency, and so they are working on deciding whether we're going to do an unsheltered pit count. HUD only requires that we do an unsheltered pit count on odd number years, and we did that in 2025. So we're looking at some options for doing that in January of 2026. It's not required in 2026. We hate to not do it, but with community safety being brand new to this process, they have not had a lot of time to really organize and plan. So Samantha Smith with the county and Drew Woten with Open Table Ministries are working together with a sub work group to determine how best we're going to handle the pit count for 2026. So it's changed. Long answer there to your question, but it's changed recently to community safety, and the HEART team will be doing it moving forward.
And Helen wears a lot of hats, but she is now co-chair of the Policy and Planning Committee for the Homeless Services Advisory Committee. And I'm on that committee, so we're really lucky to have Helen with us.
And past chair for the HSAC.
And to help with this.
Yeah.
And past chair for the HSAC, right? So she knows a lot about this stuff. So Helen, besides needing to change and use the HMIS data, what would you recommend as the three, as which objectives to focus on?
The needs and resource assessment on housing for individuals is probably going to be, well, this is specifically for SUD. I know that Community Solutions is working on a strategic plan for housing and homeless services in Durham right now, which we hope to have early next year to present. But they're not going to be specifically focusing on SUD. So, and Lacey has done an amazing amount of work on knowing what those needs assessments are. So while that's definitely needed, that may not be a highest priority at this point because of all the work that Lacey's already done. She's pretty amazing. I'll just say it right here in front of everybody.
Oh, thank you, Helen. You're amazing too. Right back at you.
Oh, thank you. So I like the day center. I know the RFP went out. I'm not sure where we are in that process of having a day center, but I like the idea of that. And definitely adding the additional beds. So those two I would definitely say. And then if we want to pick one of the other four or combine a couple, I would agree with that, of course. But E and F I would definitely agree with.
So maybe could we combine B, C, and D together? And then also do E and F with it?
It'd be a long
yeah, and maybe make it an emphasis, combine B, C, and G, and then make it an emphasis on the Black African American, because we know that that's a disproportionate amount of our homeless residents are Black African American. Disproportionate amount of our substance users are Black African American. So I don't want to lose that focus, but
well, what about focusing then just on C and D instead?
I mean, if you want to do all three, it will be a giant list. There you go.
Well, yeah, I mean, to Helen's point, in terms of why people are homeless, there are so many different reasons, right? Not necessarily connected to substance use. And so where we see substance use disparately is with chronically homeless, and as Helen noted, a disproportionate number of unhoused people are African American, also suffering from behavioral health and substance use disorder. So maybe we should really highlight those two. Anyway, open to whatever other people think.
So we would focus on chronically and not total. I think that's probably good. Does anybody else have comments before I erase it?
Because that is a very good point, that the substance use is seen more often in the chronically homeless than in the short-term ones. So,
I mean, we could say with it and reduce the number of chronically individual by 10% in every racial category, or is that too? So making sure that it's not just all among white people, or should we have a higher bar for reducing among Black and African American individuals? Something like that.
I think we said 10% for the other one, 20 there.
Okay. For I was saying that, then you're saying that 10% of the total, but also within each racial category, 10%. Making sure it's equal. And do we want chronically homeless here too?
Yeah, definitely.
Okay.
I think you have that on the top.
Yeah, and then I just added it to the African American.
Oh, okay.
Part. Okay. Can you guys see what I've changed so far? Or is there a delay?
No, we can see it.
Okay, so how does it look?
Maybe say reduce the total number of overall chronically homeless, and then you're specifying the Black African American separately as well. And that way there's no misunderstanding that we are talking about the overall chronically homeless and an additional focus on the Black African American population. Does that make sense? Say overall chronically homeless individuals. I guess we need to
Yes.
add the word homeless in there.
Oh, you're right. Sorry. So what was the other
Just now.
change? Yeah, chronically homeless individuals.
Oh, you
I
got
think the second one I think we were going to just leave African Americans as just homeless, not just chronically homeless.
Right.
Oh, okay. I like that. That's a bigger goal. I mean, we could do both, but
That looks good to me. Thank you.
Now, before we move on, I want to try to keep us. We have some wonderful speakers here today, and we want to let them be able to share. So, anyone before we move on from this item?
does everyone like what we've come up with? Thumbs up?
Yeah, I do. I think on that second one, I know it just says substance use, but I think we should add something in relation to like co-occurring disorders.
Oh, do you want me to bring it back up?
Yeah.
Okay. The second goal.
I'm sorry, I was on mute. Under goal 4, where we
goal
just
4.
were in
Okay.
B, it just specifies substance use disorder. But we also, in my opinion, should have co-occurring disorders.
Oh, okay. Yeah, that's a good idea. Like that. All right.
So, Lacey, just move that second and put a comma.
Yeah. Well, connection to treatment for substance use disorder and co-occurring disorders and harm reduction. It's treatment
okay.
to
I
both,
see.
and then harm reduction
Okay.
resources is separate. Yeah.
It might read
Okay.
better.
Okay. So,
if I may, it might read better if you put connection to harm reduction resources and treatment for substance use disorder and co-occurring disorders.
Sounds good to me.
Mm-hmm.
right, awesome. Anyone else before we move
Excuse me,
on?
Helen, what
that's
is
good.
HMIC? What does that stand for?
HMIC?
It's HMIS,
HMIS.
Homeless Management Information System.
Thank you.
Great job, everybody. I think we're ready to move on to our speaker. Wendy, do you want to do the honors?
Actually, I'm going to pass it to Lake for the introduction.
Oh, sorry, sure.
Or Tremaine.
Lacey, it's yours.
Oh, for our speaker, yeah. So we've got Tracy Freeman Hines here from Healing Transitions, which is one of the models that were identified as a good continuum of care. It's in Wake County. They have they have a very good continuum of care. And I sort of asked Tracy last minute, so thank you so much for coming and preparing something. And I think you were going to bring a co-worker with you. Is that she on? I'll let you guys introduce yourselves. Hello. Tracy, we can't barely hear you somehow.
Can you hear me now?
Yes.
Yes.
Okay, so I think I just need to speak up a little bit, right? Good.
You're good. You're
Okay.
good.
Thank you, Lacey, so much for reaching out to ask me to share about healing transitions. My name is Tracy Freeman Hines. I'm the Director of Recovery Services. I've also invited my coworker, Kathy. Kathy, if you want to introduce yourself.
Sure. My name is Kathy Worley, and I am the planning room coordinator for the women's campus here in Raleigh as well for Healing Transitions.
So I know you guys are kind of tight on time, so I'm gonna give a short overview of what our services look like. I would like to also invite Kathy to kind of share her experience as a former participant, alumni of the program, and now staff. Just really kind of focusing on the importance of that continuum of care model, and how it's really successful for people's recovery. Um, so I have been with Healing Transitions for since 2014. I provide oversight of the operation of our long-term recovery programs at both the men's and the women's campuses. Our Healing Transitions is a social model recovery program that's been serving Wake County since 2001. Our mission is very simple. We serve the homeless, uninsured, and underserved adults who are struggling with alcohol and other substance use issues. With the goal of providing them hope, recovery, and community to be successful, and have a better and improved quality of life. To start, Healing Transitions actually began as a response to a 1997 gap analysis that revealed nearly 2,000 individuals experiencing homelessness in Wake County. On any given night, 65% of them actually had a substance use disorder. At the time, the existing shelters in Wake County would not admit people who were intoxicated, leaving emergency departments and EMS as the default first responders. EMS during that time made over 2,000 transports that year, and just two individuals accounted for nearly 20% of those calls. Recognizing this unmet need, our founders, Maria Spalding, Barbara Goodman, and Fred Barber, actually went to Louisville, Kentucky. There was a model there called the Healing Place. That they were really interested in. They liked it, they loved it, and decided to bring it here to Wake County. And so we have been in operation since 2001. We are currently known as, we started off as the Healing Place of Wake County, and a few years back, we changed our name to Healing Transitions. So the services that we offer, first and foremost, is a safe non-medical detox and a long-term recovery program. Our recovery program is about 12 to 18 months long. We have a non-medical detox at both campuses. Our men's campus has 22 beds. Our women's campus has 10 beds. For our long-term recovery program, we are actually in the midst of expanding both campuses. The women's campus has already been expanded, with about 124 beds for the recovery program. At the men's campus, we're looking to expand to 290 beds. Let's see. So we do provide a full continuum of care. This includes, again, the non-medical detox, which allows people to safely withdraw in a supportive peer-led setting. We have an overnight emergency shelter, which is pretty, I don't want to say is unique, but it kind of meets the need of individuals being turned down to enter a shelter because they're under the influence. So what that means is that we operate a wit shelter, meaning we do not turn anyone away who is under the influence. We do kind of, if they are under the influence, we do attempt to kind of offer them detox services if they need it, and kind of monitor it that way. Let's see. Our long-term program is very unique. So we are not clinical in a sense, where you see, maybe ADAC. We are a social model recovery, which means it's peer-led. Our recovery program, the participants in our program have a huge responsibility in kind of running the program. And what that looks like is, clients are assigned different jobs, such as buildings and grounds, working in the kitchen, um, working in laundry, things of that nature. And in doing so, they get to learn skills such as teamwork, leadership, supervision, um, uh, all the things. We also have a community, what's known as a community process, which addresses attitudes and behaviors or maladaptive behavior that's not conducive for long-term recovery. This is also peer-led. What that looks like, is peer accountability, which also teaches self-accountability. So one peer may come to another peer and address them on being late for class. And in that conversation, there's actions or writings that are suggested to help modify that behavior. In the process of that, peers actually learn how to have courageous conversations with one another. They learn how to hold each other accountable, thereby holding themselves accountable. In the long-term recovery program, we utilize a curriculum called Recovery Dynamics, which teaches tools, education about addiction, substance use, teaches recovery, relapse prevention skills. There is 28 group sessions in the curriculum, and that is how our long-term recovery is pretty much set up. There are certain groups of group sessions that a person has to complete and transition to the next in order to navigate through our program. Usually, it takes someone maybe 9 to 10 months to get through everything. Um, Once they have completed our curriculum, they get to transition to the last portion of our program, which is called CTR2. It's a transitional portion of our program where they work with a caseworker or a case manager to kind of work on goals such as budgeting, job skills, any goals that they want to achieve prior to transitioning out. One of the things that we work on a lot is ensuring that folks, when they do transition and complete the program, that they're transitioning into sober living. We partner with an apartment complex. I'm sure you may have heard of them, Passage Homes. We manage, I want to say it's 24 units called Job's Journey. And those apartment units are specifically for individuals who have completed our program. Um, we also utilize Oxford House recovery homes as well, to help folks kind of transition into that sober living environment. Um, we also, beyond that point, we offer specialized and supportive services. We understand, and I'm sure all of you kind of are well aware, there is an uptick in severe mental health that's happening, and there's also a breakdown within the community of the resources needed to address mental health, right? We don't, because we're not clinical, we don't have mental health staff on our staff. But we do outsource to community partners such as Carolina Outreach, Monarch, other mental health providers. Same thing as far as physical health. We partner with Advance and some of the other places to get folks connected to a primary care provider. Um, just recently, probably maybe a couple years ago, we have been, because our program has been abstinence-based, there was a need within the community that was kind of saying, hey, what about the individuals who suffer from opioid use disorder? So, in not wanting to change the culture of our program and how our program works, again, being abstinence-based, we have partnered with Moore's Clinic and Southlight to offer harm reduction, to offer MOUD services, and that may, yeah, super happy about that. It was Definitely an uncomfortable shift for a lot of staff, especially since, since 2001, we've been abstinence based. And so that took a lot of education, a lot of training, and I think we're seeing a lot of success with it. People are recovering, and I think that's what we were kind of shooting for. So we do offer those services. And what's really great is because there's vans that are coming to our facility. It's not taking them out of our long-term recovery program. That was one of the barriers that we are running into, having to transport people to South Flight, and they're there all day, and then they miss a lot of the pieces of the program. And so with that barrier being addressed, they can still continue to participate in the program and get the harm reduction that they need. Trying to think. Child and Family Services. At our women's campus, we have something called Bright Spaces. We have staff that work with participants who are working on reunification, who may be working with child support, CPS. To help with reunification, to help with child visits. We have a couple of rooms dedicated for those visits on the weekend. We had to shut down back in 2020 due to COVID, but I'm happy to share that we were back up and running. And so it was really great to see the little kids kind of running through the hallways, spending that necessary time with their moms. So let's see. I'm trying to think if I'm pretty sure I am forgetting some things. We talked about non-medical detox, the recovery program, child and family services, CE, coordinated entry. I heard you guys kind of talk about day programs. We do work with Oak City Cares and manage a coordinated entry list. Currently, we have 25 beds dedicated for individuals who are just trying to work on goals and get connected to housing. What that looks like for coordinated entry is that they have a 14-day guaranteed bed as long as they're working on specific goals. And it doesn't even really have to be housing. It could be, hey, I need my birth certificate, or hey, I need an ID. As long as they're working towards some goals with a case manager, they will have that bed. Um, it looks like, and I don't know if I need to be saying this out loud, looking to increase the number of CE beds that we're offering, which is great. I know you guys have probably experienced some funding cuts as well in the community. We were operating a drop-in shelter at the women's campus, of 75 people, and we've had to drop that down to 30 people. We may be looking to drop that down to 15 people. And, obviously, we have a group of women, and there's a lack of shelter in the community. So we've been working with a lot of community partners to kind of help find some solutions with that. I think we're getting there though. Um, Guiding principles for our program is really just a low barrier. We have a low threshold. If anybody is interested in getting into our program, all they have to do is walk up to our door. We'll do a screening for services. If they're eligible for the recovery program, meaning, you don't have to use to come into our program. If you tell us that you have a history of substance use, you can come on in. Um, there's not many things that would keep you from engaging in the recovery program. We do consider severe untreated mental health, primarily because we don't have mental health staff on our crew. We try to work with individuals with severe and persistent mental health by getting them connected prior to coming here, making sure that they have at least a 30-day supply of medications. And we try our best to kind of work with individuals who may struggle in that way. There's no cost to participants, but it costs about $55 per day to serve one individual, but the participants don't see that cost at all. So all of our services are free. So outcomes, uh, 1 year after program completion, about 65% of our graduates remain in continuous recovery. I'm pretty sure that number is higher. I pulled this from old PowerPoint. 95% of our alumni are in housing, 88% are employed. Um, Real key factor, and I'm pretty sure you guys kind of know this, that research consistently shows that the length of time a person stays engaged in recovery supports recovery support plays a key role in their long-term success as a whole. Extended participation in residential or peer-based programs helps individuals build stability, strengthening their coping skills and maintaining recovery beyond treatment. So time is the one thing that is special about our program. And because we don't rush people out the door, as long as you're, working on your goals, you can stay as long as you need. We have a philosophy as many times as it takes. As you know, we have individuals who may stay in that pre-contemplative stage of recovery and they're not kind of sure if recovery is what they want. And sometimes they cycle back in and out the door, and that's totally okay. We try our best to meet with those participants who are struggling on a regular basis and come up with an individualized plan to help keep them engaged. So that is a pretty special piece of our program, that we don't shut the door on people. Um, so what I'm gonna turn it, because I've been talking a lot and that was a lot of information. I'm hoping that we're gonna have time to answer any questions, but I do want to turn it over to Kathy. She has a very unique story that I want her to kind of share and really kind of touch on what that continuum of care looks like for her recovery.
Well, I want to say thank you so much, and please don't feel rushed. I will make whatever accommodations there are, so I don't want you to feel like you have to stop what you want to say. Please don't. Just take as much time.
Well, I love talking about healing transition. So, I mean, you're probably gonna have to tell me to shut up. Don't give me, don't take the leash off.
I was about to say, thank you, Tracy, but everything that Tracy said, I second that notion. I was sitting over here looking at my notes and I'm like, she's doing a fantastic job going through all of this. So my name is Kathy Worley and I am the planning room coordinator, as I said before, over at the women's campus. And I feel a perfect example of what the continuum of care looks like and what we're able to provide at Healing Transitions. I arrived at the doors of Healing Transitions in 2019, a very broken individual. This was someone who my story had started out a little different. I was not someone. I come from a great family, come from a great home. I was a pharmaceutical sales rep, ended up with an opiate addiction. And then it became a methamphetamine addiction. Then it became a fentanyl addiction. So for 16 years of my life, I was on heroin, methamphetamines, and fentanyl. When I arrived at the doors, I was homeless. I had absolutely nothing left. I was unrecognizable. When I looked in the mirror, I just felt completely soulless. And I had been arrested again and again and again, and naturally was in this cycle that was detrimental to myself, to my family, but I didn't know how to stop it. I knew what I was doing was killing myself, and I had no resources whatsoever because I had no health insurance to actually get any kind of education for myself or get any help or find any kind of support system that would help me get through addiction. I had pretty much resorted to the fact that I was going to die an addict, and that was just how life was going to be. So when I arrived here, unlike many, I did not have to use the detox services because I had to detox in jail, which is a very hard way to go, especially from fentanyl and heroin. That was the worst experience of my entire life, and it was tough, but I made it through. And when I arrived at the doors of Healing Transition, Healing Transitions. It was amazing what I felt when I walked in, because I knew it was a place that was different, because everybody was walking around, how are you doing? You know, so nice. And I love you. And I'm thinking, you don't know me. How can you love me? And this place was just wrapped with love everywhere that I went. And from getting up in the morning down in the shelter to, you know, someone waking you up at 5:30 and giving you some kind of responsibility and accountability, that was so important for me because I lacked so much structure. You know, I kept lying to myself and telling myself like I can get sober all by myself, right? Or tomorrow things will be different. And tomorrow I can get back everything that I've lost. Tomorrow came and went and I was never able to do that. So I needed the structure that HT provided for me. And that is where it started from the first day of engagement with the program. You know, we say that the first phase of our program is built to really find out like which of these ladies really want recovery. Some are here because their parents made them come, some are here for other reasons. And it comes down to, if you're going to get sober, you have to get sober for yourself, first and foremost, right? So, learning that whole piece of it, going down, waking up at 5:30 in the morning. But there was one thing I kept telling myself, like, I'm not in prison, right? So this is a good thing. Everything else is up from here. And eventually, as you go through that process, the first phase of the programs is called MET1, which is motivational engagement track. It's just to get you motivated. You start going to classes, you start learning about your addiction, why I do what I do, and learning about the brain, which for me was a very big sigh of relief because I stopped feeling like I had moral failure. I started to understand that, you know, this was beyond my control, that, you know, I was an addict, and I could, you know, find some peace in saying that and asking for help and acceptance with that. And I was in the perfect place to do so. When you get out of MET, you go on, there's two phases with MET. You go on to the CTR1, as Tracy talked about, which is where you go up in community and your peers hold you accountable for certain things, such as being late, a job irresponsibility, a bad attitude. We say in the CTR1 community and CTR2 that we are a reflection of each other. So I can see you before you can see yourself, right? We're able to look at each other, know when someone's trying to manipulate us. We also know when we're trying to manipulate someone else. I needed that as well. I needed someone to tell me, you know, the things that everybody around me was co-signing. I needed someone to say, hey, like, that's not okay. You're stepping on someone else's toes. You're overstepping. You know, why are you talking that way? You know, this is not behaviors that are conducive to recovery. And they were right. So I got to take a look at myself. I got to break down the walls that I had put around me to try to protect me from being hurt. And I got to break those down, and I got to rebuild those and learn coping skills here with ladies, you know, 80 ladies around me that loved me and that were going through the exact same thing that I was going through. You know, it didn't matter where we came from. We all had the same thing in common, and that was trauma and hurt. And so we were able to share that common bond. And it was a beautiful thing. At first, it's very intimidating, but as you go through and as you gain sobriety and more maturity with yourself here, you start to learn that everything here is done in love. And as Tracy says, and I say it too, in our community process, this is a spiritual process. You know, whatever your higher power is fine, but this is a spiritual process. Make sure your intentions are good and we're trying to help someone, not harm someone. So that's super important. Then the continuum of care, when they decide, or when it's time for them to go to the final phase of the program, it is CTR2, which is at that point when the participants are giving back to Healing Transitions by doing a commitment in the building of their choice. So they can, you know, do building and grounds. They can do detox. They can do in the planning room, which is under Tracy and myself, where they're, you know, doing the daily functions of the program. And they are paid a stipend as well. During that time, they start to budget with our transitions case manager, start to save up money. They have to have, I think it's $1,000 before they actually move out and go into sober living. In order to be alumni of the program, you are required to stay in sober living for 90 days in an Oxford house, whatever, you know, that may look like, but for 90 days, and then you are considered alumni of the program. The really cool thing about Healing Transitions is that it doesn't stop there. when you leave or when you are considered alumni of the program, we still have community outreach. Once you are alumni of the program, the doors here are always open to you. You are more than welcome to come in every day. We want to see you. We want you to teach class. We want you to go and talk to the ladies about what your recovery looks like, what your experience here was like, to offer them some hope and encouragement and inspire them. So when I left the program, you know, it taught me a lot, because I talk about this when I at my peak performance, you know, I was a pharmaceutical rep. At my worst, absolute worst, I was homeless, had nothing, had absolutely nothing, not a dollar to my name. When I left this program as an alumni, I walked across the street here and I went to go be a gas station clerk at the fuel warehouse, or the fuel, what is it called, Tracy? I can't remember the name of the daggone, Eagles. It was Eagles back then. So I walked across there. I went to go and I was like, you know what, no matter what, because I had humility, I was like, I'm going to be the best clerk that I can be. I enjoyed that job so much, right? I mean, I enjoyed it so much, and I learned so much. And I kept telling myself, like, things are going to be better. We talk about trusting the process, and I just had a continuous flow of women around me all the time that were telling me, like, you're doing great. You can do it. You know, keep going, keep going. I went on from that job to started to work. I came over and told the coordinator in detox, I said, I'm going to work here one day, and I'm coming in strong. Like, I'm going to tell you, I'm going to get my stuff together and I'm coming back. I did. I interviewed for that job. I got hired as part-time in detox. Then I was promoted to full-time in detox. Then got promoted again to the planning room team lead in healing transitions, to where I am now, which is, you know, right underneath Tracy, whom has been such an inspiration in my recovery journey, to the planning room coordinator. And I am in school currently again. With Health and Human Services to go and help others. And HT is still continuing to support me. They allow me to do that, you know, and so they continue to push and grow. And a lot of our staff here are alumni. So, I mean, I would dare to probably say 75% of the people that are here working are alumni that have came through the program. So we can do exactly what I'm doing with you, and that is share our experience and say, hey, you can do this, you know. Um, no dream is too big. Let's put it in action, you know, let's go get that. So it is one of the most important things. The continuum of care is one of the most important things that I feel Healing Transitions has to offer. They continuously wrap you in love, and I feel like that with a model like that, there's no way that you can't be successful if you apply yourself and have the willingness. So thank you so much.
Thank you. Yay.
Real quick, I forgot to talk about the most important piece. I think we both did. So yes, we have a recovery dynamics curriculum where, you know, folks are kind of going to class and they're learning about their substance use and, you know, coping skills. At the same time that they are attending those classes, they are also completing written assignments associated with those classes. But in addition to that, they are expected to attend outside meetings or outside 12-step meetings. So this piece is really important. So is, you know, the assignments that they're doing in the program is similar to maybe the step work that they would do with the sponsor. So it's kind of like you're getting it from both sides, right? And so the expectation when you get to Met 2 is that you're working on finding a sponsor. In one of the 12-step fellowships, that you are building a network of people who have a lot of recovery time that can support you when you leave or transition out of the program, and that you're also working the steps with the sponsor. So that I forgot to talk about that. That's like super important. So we have a great relationship with the 12-step community here in Wake County. We people are successful. I'm not saying not everybody likes 12 steps. Not everybody subscribes to 12 steps. But for a lot of people, it has been successful in conjunction with time, in conjunction with the residential treatment program, and all the things. So if you guys have any questions, let me know.
Well, that's a good
Where do
way.
you,
When thank you so much for both of y'all sharing your stories and telling us more about this program. Um, I didn't mean to cut you off, Lacey,
that's okay.
but
I was
you go
just
ahead
gonna
and ask your
ask,
question. I just want to thank y'all for that and go ahead.
yeah, thank you. Definitely. I also want to say thank you for coming. I was wondering where you get your funding because that's obviously one of the hardest things.
It is. So don't laugh, but one of our biggest funders is the ABC board. Um, that's one of our biggest funders. We do have a lot of grants from Wake County, in-kind donations from the community, but one of our biggest funders is ABC board.
What about the opioid settlement money?
Yes.
Do
Yeah.
you have
So
some of that?
I'm glad you mentioned that because we have because I forgot to talk about our rapid responder program. Some of our peer support in the rapid responder program where they actually kind of go out and meet with individuals who have had like a recent overdose. There's a report that gets ran, and those individuals who are on that list that present at ER for a overdose, rapid responder will go meet with that person, connect them with resources. Sometimes it may be connection to Southlight, Moores, it could be connection to our program. And so a lot of the some of the funding that we get with that funds rapid responder program and peer support.
So, what hours are your rapid responders working?
Probably they're burning the candle at both ends like we all are. I'm not sure what the hours are, but I do know they're out here early. When I come to the men's campus, one of the things they do is a ride along with EMS. They I think when I get in, it's probably about 8 o'clock. At the latest 8:30, the EMS ambulance is already out there. They hop in and they go make their rounds to individuals who are on that list. They also do community outreach for individuals who may be unhoused or chronically unhoused or unsheltered. They do a lot of work with individuals who are in tent encampments. We actually, I don't know how long ago it was, Kathy, where we just decommissioned an encampment across from our men's campus.
It was in, I was just talking to Chris about it today. It was in May.
In May.
Mhm.
And so some of those folks were connected to Bridge to Home where they were housed. They were properly housed with a little bit of funding to help with that. That was a pilot project that was happening, I believe, with Wake County. So they are doing a lot of work in the community to get people housed and get them connected to resources. Um, is there more work that needs to be done? Absolutely. It's like when you decommission one tent encampment, another one pops up. I don't know if anybody's really familiar with Wake County, where the gentrification and the closing down of some of the low-income housing downtown, going through Boyer Street or New Bern Avenue, all the way up to past Wake Medical. There's been a huge loss of housing for low income people. And you can see that clearly when you're going through intersections and there's an increase of individuals at the intersections, panhandling. There's a lot more work that has to be done. The homeless population is continually increasing. We're seeing the impact of it here. We're seeing the impact over at our men's campus, and the need is really great.
Tracy, one question I do have, just speaking about y'all have a bunch of services, a bunch of things in place, but what service or program started first as y'all and then expanded on?
The non-medical detox, which trickled down to our wet shelter. So it kind of encompassed both of them at the same time. So again, the specific need that needed to happen was we needed to provide shelter for individuals with substance use issues or alcoholism. And what that turned into is, hey, here's this non-medical detox that you can, go. We called it the Sober Up Center, that you can come sober up. But because it was a wet shelter, you can just, if you didn't need detox or didn't want detox, you can have a bed here. And it just kind of grew from there.
Thank you.
How long do people, on average, stay in the non-medical detox shelter?
It's very dependent. So there's two separate things. There's a non-medical detox, and then there is the overnight shelter, or what we call the wet shelter. Um, so for our non-medical detox, it really depends on the substance that you're presenting to detox from. We utilize COWS and CY scores to monitor their withdrawal symptoms. And if they're pretty low, it may be 1 or 2 days before you discharge. If it's, if it's still kind of high, we may keep you a little bit longer. If it's above our threshold, we will send you out to a higher level of care. You're welcome to come back to engage in the recovery program. Um, because it's a social model recovery, a social model detox center. And what that means is current participants in our program who may be in MET 1, they could be in MET 2, they could be in CTR1. They are actually responsible for escorting detox clients to classes. So that kind of helps with engagement and motivation. So we have a lot of clients engaged in our detox center who may say, hey, I want to complete a screening for the recovery program. So they do have that option to come straight from detox to a recovery program, or they have the option to say, hey, I'm not interested in the recovery program, but I do need shelter, and they can have that option as well.
I just want to thank both of you for coming to our meeting and spending so much time with us. It's really inspiring to hear your story, Kathy. Am I saying your name right? Is it Catherine or Kathy?
It's Kathy.
Okay, Kathy. Really inspiring to hear your story. Thank you so much.
Thank you.
One thought that one thought I have in mind is maybe at one point we could do a field trip. I mean, you all are not far to go and visit. I think that would be great if we could at some point arrange something like that, come and see, what you're doing in person.
We would
So
love to
that
have
was one
you.
thing.
Yeah, Lacey has my
Awesome.
contact information, and I think we both may be on the email thread. Like anytime you want to come out, we got you. In either campus, men's or women's.
Okay, awesome. And the other thing is, I guess I don't know if you're familiar with TROSA here in Durham and how you would compare kind of your approach and what you do compared to TROSA. If you know what, I mean, maybe I don't know if you feel comfortable saying that or not, but I was curious.
So I toured TROSA probably maybe 6 years ago. I was intrigued with some of the components of their program. One thing that we struggle here at Healing Transitions is relationships. So, we have this saying, the one thing that will take a person out of recovery is what is it? Love and money. Um, and so we struggle with providing individuals the tools they need to kind of set appropriate and healthy boundaries. And so a lot of times what we see happen is, and this is probably not unique to a lot of programs, but they'll get into these relationships. They stop using, they stop drinking, and then the next thing they're in a relationship, and it is such a distraction in our program and a distraction to their recovery. The one thing that and I don't know if they're still doing this, but they had I don't want to, I guess, a class or a curriculum on boundaries, healthy relationships, and you were required to go through that process in order for you to start dating. I don't know if I wanted to go that far, but I think we do need some type of curriculum to kind of talk about boundaries, healthy relationships, all that kind of good stuff is something that's really needed here. Um, I kind of compare TROSA. I don't know. It's more work related. There are some clinical components to it. There's something special, and I don't want to compare programs or anything. Of course, I'm partial to Healing Transitions, but there's something really special about the peer-to-peer model. or social recovery model. I would probably need to tour them again I'm not saying it's a horrible program. I think they do great work in the community. But it was something different from our model. I'll just say that.
And they
Okay.
don't have
Thank you.
a non-medical detox or a wet shelter. So that's like a big difference. Sorry, Wendy, I didn't mean to cut you off.
Okay. No, yeah, no, that's helpful. And since you guys have started, you know, doing MOUD, what kind of changes have you seen since that has been offered to your residents?
Kathy, I'll let you want to chime in on that one?
So it was like Tracy said, it was an uphill battle for a little while, you know, with staff and with participants. So what we have done in the past probably 2 months, I would say that we have seen a larger reception for the MOUD. At first, there was a lot of judgment, and I think that judgment came from the lack of education as to what MOUD was and the success rates and understanding the opioid addict and the harm reduction that was behind it. So we have worked very hard here on a monthly basis trying to implement those classes as far as education with the participants, and then also educating our staff as well, like bringing in guest speakers, talking with people that are at Morse Clinic or South White, trying to educate ourselves, having them come into staff meetings. So pretty much now we're on the flow of the norm because we're implementing more meetings and more educational classes for both. So it's been received a lot better, I would say, probably in the last 60 days.
Thank
The
you.
the stigma is still there, though.
Yeah, absolutely.
You know,
100%.
and I think that's probably, it's going to change. It's going to get better. And the reason why I say that, I think some of the stigma that exists is because we don't see the outcomes, right? We may kind of assume that people are, on MOUD because, they the stigma is they want to get high. But we also know that as the gold standard of care for opioid use disorder. But I think one of the problems, barriers for our staff and participants to really kind of get on board with that was because they didn't actually see the recovery outcomes, the successes. So I'm really interested in the next few years to kind of to see what the outcomes are, like how many individuals who came through our program on MOUD became alumni, holding down jobs, getting their families back. Those are the kind of outcomes that we really need to see in the community so that stigma can decrease.
Thank you.
Well, again, thank you so much. Wendy, were you going to say something? I heard somebody take a breath. Oh,
It may have been me just looking at time, knowing that you have to live in 7 minutes.
don't worry about it. It's okay.
Okay.
So I think now we're ready for our committee reports. And so I'm going to pull up Lacey's slides, hopefully. Uh-oh. I'm going to have to.
And I just want to say, Tracy and Kathy, you don't have to feel obligated to stay if you
Yeah.
don't want to. And we will definitely follow back up with you about a
Thank
visit.
you.
Thank you
you for
so much.
We look forward to hearing from you.
Absolutely. Bye-bye, ladies.
Thanks.
Thank you so
Gentlemen.
much.
Great.
Well, now the next thing on the agenda was Tremaine was sort of going to lead us in a discussion about how we could do a continuum of care. Well, similar to healing transitions, but we may not have time for that. Tremaine, did you have anything planned for that? Or I don't want to skip over you. It is on the agenda, right?
I think it was more discussion maybe, well, I guess I thought he was leading the discussion after their presentation, but
Yeah,
which we just did basically.
that's what I
Yeah.
thought it was as well.
Yeah. Okay. So let's so everybody's
that
okay with
sounds
moving
like a
on.
great discussion for our next meeting, though, Lacey.
Yeah. Right. And we did want to have, I mean, we tried to get Carlisle because that was number one on the suggestions for him to talk about continuum of care. So we'll hopefully have him next time. Okay. Well, we don't have a lot of time. Most people on the meeting right now, I think, actually attend the treatment committee meetings. So I'm not going to spend too much time on this update, and y'all can read the committee report. I'll just go quickly through. But uh, the big news is that we changed our name. Used to be Mental Health and Substance Use Disorder Treatment Committee. And so now we are the Treatment and Harm Reduction, or THR Committee. And basically, just recognizing that harm reduction is critical to our mission, wanting to put that somewhere into one of the committees. And it just that so many of the people that come regularly to our meeting are heavily involved in harm reduction, including myself right now. And we have representatives from the North Carolina Harm Reduction Coalition, and a lot of our treatment providers also provide harm reduction. So it made sense. And really, treatment and harm reduction are interconnected. Our biggest harm reduction tool is one of our biggest is naloxone, and naloxone is also a treatment for overdose. And then finally, the name was really hard to say. It was such a mouthful. So it's better, and it matches better with the other committee name, which is much simpler, prevention and education. And so everybody was on board with the name change. Next slide, please. So one big thing which we touched on at our last quarterly meeting, towards the end of our last DJT quarterly meeting, was announced that the RI's Durham Recovery Response Center decided to close the outpatient treatment center, which was kind of a shock to a lot of people. So we spent some time in committee talking about this. We invited Joy Brunson Subuga, who is part of the leadership of RI, to come talk to us and explain the decision. And basically, she said that the outpatient program was never really meant to be permanent, from what I gather. In 2018, they wanted to be able to start people in the crisis unit on MOUD. And there were so many restrictions at the time. They weren't allowed to give a prescription, a bridge prescription. So they decided to start their own on site. And now that the restrictions are so much less, and there's so many more people providing MOUD in the community, they felt they didn't really need to continue it. And RI's number one priority is crisis. So they wanted to just focus on their crisis services and do what they originally intended, which is to refer people out to the community. There were 100 people receiving treatment. So the CLC peer support specialists worked really hard to connect all of those people with new treatment providers. So they went to Morris Clinic, Lincoln, Freedom House took some of those patients, and it was great having the connections of the committee to help, facilitate this. The CLC program will continue. At the last meeting, we weren't sure if we were going to get refunded, but they did. And so there's still 3 peer support specialists at DRRC. Kim Jansen was the head of the outpatient program. And so when that closed, she transitioned to now being the full-time coordinator of the CLC program. And then I transitioned off of that and am now working full-time on Durham County Public Health's harm reduction program and naloxone distribution. And so our peers will continue to do peer support at DRC, but also in their new treatment homes of the participants. Next slide. We had Dr. Jennifer Carroll come speak to us about medetomidine. I think Donna did email the DJT task force fact sheets on this, which I encourage you all to read, but it's a new emerging opioid adulterant similar to xylazine, but much more potent. Luckily, it doesn't cause skin wounds, but it does cause withdrawal that can be fatal. Very fast heartbeat and high blood pressure, constant vomiting, shaking, and we really need to look out for this. It's now, showing up in North Carolina, possibly in Durham, and people may need to go to the hospital. Also, it's very long sedation, so by the time people wake up, they're in full fentanyl with full opioid withdrawal. Just like xylazine, naloxone doesn't work on it. But the important thing is to get people breathing. They may still be passed out. So we talked in committee about new guidelines for overdose response, and just getting out the information on medetomidine to our emergency responders. And Duke Hospital EDs are working on getting people educated about what they might see from this new drug. Next slide. And then finally, we have our wonderful housing subcommittee that continues to meet monthly. Kay Sanford had to step down as the chairperson, but now we've got David Crispell, who's the head of Jubilee Home, and they just opened a women's house, by the way, which is very exciting. And he's been leading some of the county and city efforts to address the housing crisis. So he's a great person to lead our little committee. Exciting news that Freedom House now officially allows all residents to take methadone if they so choose. And we had the very first person move into Freedom House who is taking methadone. So really proud of that on the committee. Also, Cub Creek Sober Living, which has several recovery homes. Through our work, they opened one women's house, and now 3 women have moved in that are taking MOUD. So that's so exciting. They have 2 other spaces open. If you guys know of a woman that needs housing, and she's in the works opening 2 more women's house and possibly another men's duplex, and will, I think, most likely make them accepting of people in MOUD. So this is very exciting. And we've also, as a committee, been trying to get a lot of the housing groups to make sure they have naloxone to distribute to all residents. So Helen and I and Morgan Culver have been supplying naloxone to these housing groups. And I've been busy updating our long list of housing providers. I just want to make everybody aware in that process, when I called Cascade of Durham, they are temporarily closed. They would not really tell me why, but it's kind of a shame because we don't have many places for women with children who are in recovery to live now. There's only one Oxford house. So it's definitely a gap, and I hope they reopen soon. And that is it.
Any thoughts or questions for Lacey? Okay.
Great report. Thank you, Lacey.
You're welcome.
And bringing up the rear, prevention and education. First of all, I want to give a huge thank you and shout out to Morgan and Jason and Dennis for supplying us with naloxone, and then now Helen. So we're excited that we continue to have naloxone to distribute, and it's just been amazing the number of naloxone kits and training that we've been able to do so far in these last few months. 695 students, these are young people ages, well, middle school and high school, to talk to them about vaping and the new marijuana. We also had 345 students that we spoke to about whole hearts, broken hearts, and bullying. And so there's a lot going on with young people. 68 youth ages 13 to 75, 13 to 17 45 young adults 18 to 24, 61 adults 25 plus have been trained on opioid misuse, overdose, safe to call, and 988, how to use naloxone. So that's really exciting. Had a talk with the superintendent who believes that every middle school and high school student should carry naloxone. And so we're talking about that with him, and things that are happening on the state level. Trained and engaged 51 health ambassadors, 13 to 65 plus, on health and wellness. I was given the opportunity to speak at the National Academies of Sciences in Washington to talk about our community engagement methods, which was really exciting. And I also created with the community a resilient recovery model curriculum. And in terms of overdoses, still the numbers going down. So I'm really excited about that, excited to see that. Still, the overdose rates among Black people remain higher than other ethnicities, with 97.4 between the ages of 35 and 44. But we're doing better. In terms of opioid visits, September, as you see, it's going down. So again, I'm really excited to see that over last year, there have been 26 less ED visits. So that's something to celebrate, I believe. In terms of fentanyl, we're going down in terms of, I think this is the year so far, but we're seeing improvements there still. Black residents are still experiencing more fentanyl deaths than other ethnicities. Um, oh, and that's it. Wow, and Melvin Green just signed in.